Treatment with venous ulcer. So, what should we do first? Should we do iliac vein stenting first? Should we treat the superficial venous reflux, or should we do both at the same time? This is a topic of debate in many different conferences. So, I think before we move on to papers and discussing this, I think we really have to differentiate between deep and superficial. In a severe form, deep venous reflux, if you have a iliac, either thrombotic or non-thrombotic obstruction of the iliac vein, I don't think you can have this patient without swelling. And this is a classic presentation. They have May-Thurner syndrome. They have severe left leg swelling. This patient may complain of severe swelling, and they may have rare but the classical venous claudication, where their legs are so swollen when they walk, they have pain, and it mimics claudication. In contrast to this, superficial, patient may not have swelling. They may have localized swelling. And when they get up in the morning, they have no swelling at the end of the day. Where the varicose veins are really severe, they may have localized swelling. They may have throbbing sensation, leg heaviness, and they can develop venous ulceration because they have so much venous hypertension in that localized area. This is a very different pathology, and the way that I think about it is venous return to the heart from the leg. 90% is done by the deep venous system. So if you have an obstruction in the deep venous system, you're going to have severe swelling. A superficial system only takes care of 10%. So if you have only superficial venous reflux, you are not going to have and you may not have swelling. But what happens is that when you look at the literature, there's a lot of papers out there that shows very positive results. This is from the European Society of Vascular Surgeons 2013. It shows that deep venous intervention was effective in healing ulceration, venous ulceration. And there's multiple papers coming out of Asia that if you do iliac vein stenting, the ulcer heals a lot faster. This is a paper from Brooklyn, published in the Annals of Vascular Surgery 2012. They looked at all the patients that have really challenging venous ulceration that they were treating that were not healing, and they looked at their iliac obstruction and found out that out of the 100 patients, 50 patients with ulcer had stenotic iliac lesion, and when they were stented, 58% of the patients healed. Another paper from the Annals of Vascular Surgery in 2016. This was a small sample, but again, they looked at all the patients with ulceration that were very challenging. 60% at interrogation had stenosis, and after stenting, their healing time was much shorter. This is a little bit, to me, is a little bit more possible. It says when you combine superficial venous ablation and iliac stenting placement for complex chronic venous ulceration, published in JVS in 2016, it shows that there was symptomatic relief and a healing rate was much, much faster. And I think this is very important. It's that some of the other paper, there was some selection bias, because are you really selecting the patients that have only deep venous reflux? Are you selecting the patients that have superficial venous reflux, or you have concomitant disease? I think some of this resource leads to some selection bias. So there was a lot of controversies a couple of years ago. Peter Lawrence from UCLA looked at all the studies and said, what is the right answer here? So he actually gathered 11 centers in the U.S., and they looked at 800 patients with venous ulceration, and they basically pondered the same question: should we do vein stenting for this patient? Should we do venous ablation? Should we do both at the same time? And what they found that is superficial truncal venous reflux as well as deep venous stenosis both contribute to healing of venous ulceration. They are both favorably positively lead to faster healing. However, what is very salient about this study is that only out of the 800 patients, only about 130, less than 15% of the patient had iliac obstruction. So I think selecting your patient is very important, because not everybody with venous ulcer will have a deep venous iliac obstruction. I learned this the hard way. There were patients that were not healing for a long time. I venogram, or I got imaging all of them, a lot of them, and less than 10% of them had iliac obstruction. So the idea is one thing, is venous hypertension. You have to reduce venous hypertension that is going to lead to this, either stenting the iliac or doing superficial venous reflux. And I think treating superficial venous reflux is more important because it's closer to the ulcer bed. Even if you have deep venous reflux, unless you treat the peripheral, you might not heal that. And why is this important? Treating superficial is that we have two level 1 evidence studies with the ESCAR and the EBRA trial that shows that if you do superficial treatment, your ulcer heals faster. So yes, iliac vein stenting might be beneficial. However, I think treating superficial is much more important in these cases. These are all paper that shows that with non-thermal therapy, this is from the metastasis therapy, that you can heal also faster. So in conclusion, iliac vein stenting is a great procedure, but I think it's an adjunctive therapy for select patients along with superficial venous treatment. Superficial venous treatment are, I think in my opinion, the primary treatment in healing ulceration, because you really want to decrease the venous hypertension near the ulcer bed. And let's not forget, the most important thing about this whole treatment is wound care. If you don't wound care, it doesn't matter if you put a stent, if you do a great ablation, you never heal your patient. Thank you.